session is now open for questions from the audience. Yeah, please.
So my question is to both Dr. Murli and Dr. Niren. I would like to know their experience and thoughts on use of ECPella in ECPR and in LV unloading, NB unloading for Dr. Niren, and ECPR for you, Dr. Murli.
Can you just?
I would like to know your experience, if any, and your thoughts on use of ECPella, that is ECMO plus Impella.
No, we never used Impella, and we doesn't have that large experience. I think Murli can.
We have used few cases. Impella has been used, whether it is only for an LV support in Cath lab or in association with this, it has been used. And whatever it is, depending upon the recommended period, either 3 days to 14 days, depending upon the type of Impella.
And you think it's far superior than ECMO with high BP as
no, the advantages will be basically your LV won't be distended. Other than that, ECMO also is equally good and does the job. It is in the Cath lab, you can quickly insure. That's the main advantage. The main limitation will be the cost for it.
Yeah, it's very cost. Thank you, sir.
Any other question? Yes.
Hello, sir. My question is, in case of ECPR, ultrasound guided arterial puncture you are doing, without, you have mentioned that without interruption of CPR, how is it possible to do, sir?
See, if you look at both things going on simultaneously, one is a team doing chest compressions and CPR, a second, a team that is instituting the ECMO. So primarily, the chest compression should not be interrupted much. The chest compression should be continued, and ECPR should be done, or whatever the cannulation or guide wire puncture, whatever it is. You have to do it with the minimal possible interruptions in that. It's not that you hold compressions for full 1 minute and then do the job and then ask them to compress. No, that should not be done. Who need to wait is the team doing the ECPR, not the team doing the compressions. Because that's the key, and the most common or the challenge what you face once you successfully establish ECMO is neurological outcomes. And your neurological outcomes depend upon few factors. One of it is how quickly the CPR has been initiated, that's the first thing. And once it is initiated, how well it is continued. You see that when you do it for a period of 1 hour or 1.5 hours, that is the time for, suppose if someone arrests in the ward, it takes 10 to 15 minutes to initiate the call, okay, then to decide. It's a case which is already waiting for a transplant and all, it is clear, you are going ahead with it, there is no return of spontaneous circulation. Then you shift them down, the circuit to prime, have a word with the family, all this easily takes half an hour or so before the team starts. So by the time the patient is on ECMO, it may take close to 1 hour. So you see that beyond 20 minutes or 30 minutes, the enthusiasm for maintaining a good compressions comes down. So if you are there at a level to see the people and see the job done, one of your important job is, I feel, is to see that compressions are uninterrupted, they are good quality, and for the sake of doing the job of ECMO, the minimal possible interruptions. And where the ECMO team can wait, they should wait, not the compression team.
Thank you.
Sir, good morning, sir. Myself, Dr. Kalikovan, pulmonologist from Cuddalore. We have heard about ECPR in textbooks, but I'm glad to know that it is being practiced here. In Indian context, how do we succeed in counseling the patient attenders for getting an ECPR done? Because with the expert team, it is good that we can revive the patient, but how to counsel the patient attenders, especially when affordability is an issue and we don't know about the post-procedure days of hospitalization. How do we proceed?
That's a challenge. That's a challenge in many ways. Okay, one, you have a scenario where you know the case. That's the case under your unit. You know he's in the ward, you know the patient, you know the family. There it may not be that big challenge. You know the patient is, you may not be able to get back, you proceed with it, you know what is the cause. The patient already has a trust, the family already has a trust. Once you counsel them for this, they'll go ahead with it. It is more challenging if it is a arrest in a new situation like a Cath lab or ER, or a patient who is not prepared. There a lot of factors come into play. It is not just the cost of initiation of ECMO, which itself is significant, but the time it is going to take. What is your approach to the primary problem? What is the primary problem? Whether it is a CAD or a pulmonary embolism or a cardiomyopathy where you will end up on a transplant or a VAD pathway, or how long it is going to take, Apart from all this, the uncertainty is related to the outcomes. How long it is, I mean, what are the chances? Even if you say you can do everything also, what are the chances? It is quite a challenge, and that is one of the reasons why out of hospital cardiac arrest or in hospital cardiac arrest, patients who are not under the primary care may not accept it.
I would like to add another important thing. So the question you ask is very important. Cost is a huge millstone around all our necks. So one of the things that we have proposed and done in some instances is that in uncertain situations, like the thing Murali is talking about, these are patients who are waiting for a transplant. So the economics are sorted out. The very fact that they're listed for a transplant means the money is less of an issue than in, say, cath lab or emergency. You could use a regular heart-lung oxygenator. That is good enough for 6 hours. 6 hours gives you enough time to take a decision as to where you stand. And in case they don't pay, it's only 15,000 rupees. That's, in any case, cardiac arrest in the ICU or in the emergency room, some amount of writing off is inevitable, or the system can absorb. But this would be a better strategy. It gives you a breathing time to decision, and then you can take it forward.
Sir, a surgeon's question to Dr. Bala, sir. Suppose you are considering ECMO in a pre-operative situation for heart transplant. So, as you mentioned in your talk, what proportion of patients would get heart transplant as compared to LVAD in your experience? And suppose the LVAD is not feasible, is it that a patient, pre-op patient who is on ECMO, is it possible that he can be weaned off ECMO, or is he doomed for I mean, he has to wait and ultimately improve with heart transplant only?
Majority of pre-op patients are, at least the ones we have done, are transplant candidates. That's why they are listed and they're waiting. And we have done, I think, now 7 or 8 VADs from ECMO to long-term VAD. Long-term VADs are expensive. It's, as you know, 1 crore plus. Now that Medtronic is off the market, the cost is an issue. So what we find is beyond 2 weeks or 3 weeks, I mean, it's the ECMO stretcher it's a slow down which recoveries. You suddenly have a cerebral bleed or something, the whole thing is over. So we transition to a short-term VAD, and our outcomes are better if you have a VAD after ECMO at the time of transplant, but as compared to running on ECMO for 6 weeks, for instance. But in general, availability of affordable VADs will dramatically increase the survival to much beyond 70–80% in this.
And in the post-operative setting, sir, PGD, do you only look at the echo parameters to decide weaning from ECMO, or there are some other?
We look at echo, we look at the hemodynamics, and another thing I would like to mention is on those patients where you expect trouble post-transplant, where the donor organ is borderline, or where the recipient has high PVR and you expect trouble. It's a good idea to do a cut down or have vascular access ready. In children, we do a cut down, we tape the artery and vein with silk, and then we close the skin loosely, so that in the middle of the night when they call you, and those calls are never good news. 2 o'clock in the morning, the nurse calls you, you can very quickly institute ECMO if you anticipate trouble.
I am Dr. Vijay Shankar, Government Kilpatrick Medical College. My question is towards Dr. Murali. Murali, that was a wonderful presentation, and it's a great eye-opener for all other institutes to start this ECPR, and it completes the package of ACLS protocol. And the thing is, as far as the pump is concerned, we all know that's very time consuming. And do you keep a dry pump always ready, or if it is prime pump?
No, no dry pump, no prime pump. Perfusion team is always there 24/7, yes. And they just take barely 15 minutes to prime. CPR will be going on, someone will go and counsel them. If they say yes, in the meantime you paint and drip ready. By the time you take punctures and all, they'll prime, they'll keep it ready. A couple of perfusionists are always there.
Yeah, thank you.
My name is Dr. Saif, and I have a question for you, Dr. Murali. You said the time of CPR, I mean the cardiac compression and the quality is very important, so that we can arrange for the ECMO. So can we combine it with the auto CPR?
it is done. Yes, that's how it is practiced in a lot of Western places, not in just Western, even the Eastern side. If you look at the ECPR literature or the data, a large number of them are from the east side of the Asia, Korea and Japan. Then the next major data will be from the Europe, that is Germany and all these places. In most of these places where they do, whether it is outside hospital cardiac arrest or in hospital cardiac arrest, the standard thing is once they initiate, they put it on this automatic compression devices, and then they proceed with the ECPR. That is possible, but we don't practice.
Question to Dr. KRB, sir. I am Dr. Bala from Apollo Children's. What about cannulation strategies? You are showing us sending with biventricular for transplant. Say a Glen or Fontaine, you want to put on ECMO. You straight away choose a cannula according to the anastomosis, or you would try to give them a chance with a regular ECMO and see what would be the strategies in such situations?
See, as long as it's a VA ECMO, if you're planning to support on VA ECMO, you need a venous access. So even if it's a Fontaine, either a groin or a neck, if the complete Fontaine is good enough. The problem comes in small children, and if you have a 4-month-old child who has a cardiac arrest, and it's not easy to do a ECPR, to massage and cannulate, and sometimes, as I said, 3 o'clock in the morning, it takes time to get help, and under those circumstances, we've actually done 2 patients where, in one of them I was the only one available at that time. It was 3 or 4 in the morning. So a nurse or a duty doctor is massaging, and the quickest is just the rapidest way of getting ECPR in children is to cannulate the neck. You make a slash just above the clavicle. In literally 30 seconds, you can loop the carotid artery and vein, and you shove it in. And children tolerate ischemia for a longer time. So we've had 2 instances where up to 1 hour of cardiac massage, those children completely woke up. So ECPR is doable. In fact, we showed 60% survival long term at 5-7 years. I grant that these are patients where we had a definite solution for the deranged ventricular function, but 60-70% may not look much, but you've saved 60% of patients, because all of them would be dead if you didn't have access to ECPR.
Thank you.
Any more questions? So if there are no questions, then we'll wind up this session. Thank you to all the wonderful and learned speakers. Thank you so much.